I'm Dr. Martha Paynter, and I'm an assistant professor at the University of New Brunswick in the Faculty of Nursing, and I am, of course, a registered nurse. My clinical practice is in abortion care and reproductive health care, and my research portfolio looks at the intersection between reproductive health and the criminal legal system. I'm physically located on the unceded and unsurrendered territory of the Wolastoqey people on the Willistic River in New Brunswick, in Fredericton, New Brunswick. And I have some lovely photos of the territory in my presentation. When I do a land acknowledgement, I'm very thoughtful about there being a commitment in the work to directly address, directly respond to the truth and reconciliation calls to action. So, for instance, in my work, of course, there are the calls to action that pertain to education and our responsibilities as university educators, but also, the very first call that we reduce the number of children, perhaps eliminate the number of children, Indigenous children who are experiencing the foster care system, the family regulation system in Canada. That we, number 18, recognize the healthcare rights of Indigenous people, that we, number 23, increase the numbers of Indigenous healthcare providers, and number 30, this is how my work butts up against the criminal legal system, eliminate the over-incarceration of Indigenous people, or perhaps more ambitiously, eliminate the incarceration of Indigenous people. My work, I'm currently located at UNB, but I'm also a member of a national team called the Contraception and Abortion Research Team, CART. And we are national, but our headquarters is at the UBC Faculty of Medicine at BC Women's Hospital. A lot of the data that I'm going to be referring to today is produced by that team, and often by other members of the team that I just rely on them. And we are very well funded by CIHR. I'm very thankful for that. And I also am always working in collaboration with Wellness Within, an organization for health and justice, which is a nonprofit based in Nova Scotia that I'm currently serving as the director of research on the volunteer board of directors. And that organization started really its work in 2012 and incorporated in 2017, and is the only organization in Canada dedicated to addressing the reproductive health needs of people experiencing criminalization. And obviously, we have a major focus on access to care. Access to abortion has been a big focus of our work, particularly in the past year, with several different types of studies examining that intersection here in Canada. All right, so you can flip that ahead. We're going to talk about access to abortion in Canada and where we are, where we're going to go from here. And there's my beautiful photos of the Willistic River taken by my father. And you're all familiar with that Jamie Black image from the Human Rights Museum for that statement on reconciliation and actions. You can go ahead, yes, and go ahead again. And those are the acknowledgements. So I just want to note my research manager, Claire Heggie, and a research assistant who worked on this, Susanna Mackenzie Freeman, Julia Hutt, who does all of the illustrations in my work, and my dear mentor, Dr. Wendy Norman, and Dr. Sarah Monroe, who are the co-directors of CART. All right, next slide. So you're all familiar that until 2016, we really didn't have medication abortion as we know it, and the landscape was very different. Even though we had complete decriminalization since 1988, we were in a position where only physicians were authorized to do abortion, to be abortion providers. And I take a lot of issue with this language. It doesn't really acknowledge the interdisciplinary team on which we're reliant for abortion care provision. But nonetheless, that was the situation. We had 96% of abortion in the country was procedural or surgical. And of course, this resulted in extreme disparities in access because most of our procedural abortion facilities were located right along the border with the US or in the big urban centers. Next slide. Then we had Miffy. So approved by Health Canada in 2015, it was really widely available by 2017. New Brunswick, where I'm located now, was the first of all the provinces and territories to publicly fund medication abortion. Unlike any other prescription med that you're getting in community, there was a recognition that Miffy needed to be publicly funded. Very early on, early restrictions and regulations that surrounded Miffy were let go of. And one of the most important was this idea that it could only be physicians who prescribe. So 2017, nurse practitioners in every province and territory were authorized to become prescribers, providers of medication abortion. And many of the other regulatory restrictions that we started off with, our team, the CART team, produced implementation research very early on that showed that these were all unnecessary, presented those to Health Canada, and they were done away with. So we saw a really rapid, evidence-based response to really improve uptake of medication abortion into private primary care practice. Next slide. So what changed once we got Miffy and nurse practitioner prescribing, these two really important shifts in the abortion care landscape in Canada? Next slide. The first thing that, of course, would come to mind is what would happen to safety as such an important indicator of quality of care. And very frankly put, abortion remained safe. So looking at a number of different indicators, adverse events did not increase. Medication abortion with mifepristone is very, very safe. And so that was very reassuring. Next slide. And procedural abortion or surgical abortion decreased. So we would have expected that a bit, right? But what we saw was extremely dramatic. We went from this position where in 2016, 96% of abortion was surgical. And then by 2021, our data from CIHI that we just got this spring shows that we were below 63% surgical. And here in New Brunswick, we are below 32% surgical. So at this point in time in this province, 2/3 of abortion is by medication. The abortion rate overall has not changed. That doesn't really change. There's always going to be the need for abortion. And we're seeing, we don't have enough data to conclude that it's statistically significant, but we are seeing the rate of second trimester abortion decline. So overall, abortion is not declining, but more people are having medication abortion and more people of all the abortion patients are having earlier abortions, which is obviously what we want, so much safer for the patient and so many more options at their disposal. Next slide. So in our research, we found, looking nationally, we conducted this mixed method study about nurse practitioner implementation of mifepristone in their practice, and found, as we would have predicted, that nurse practitioners think they are very appropriate to be prescribing. They're in those communities that really could use a prescriber. They have a very holistic approach to patient care, making sure that they're addressing those things like gender-based violence, like poverty, that so often butt up against the need for pregnancy termination. And here's just this quote that really demonstrates the leadership that nurse practitioners are taking in terms of mifepristone practice at this point. You might seem like you're the only one in your practice that does it. But once other people see that it's actually pretty straightforward and very doable and a really helpful service for your clients, that you might see some momentum come from that, and that other people also want to get on board and provide that service as well. So a lot of enthusiasm from the nurse practitioner workforce. And what we found overall, next slide, in terms of what was really helpful for nurse practitioners was, being in leadership roles in their practice and in their communities, and being able to engage with their communities to educate them about what mifepristone was, how to get it, what it will involve, and also being able to have outreach and collaboration with other providers. In particular, people who could provide mentorship are also backup, right, for the rare emergent needs. However, the barriers that nurse practitioners faced really, abortion is kind of a low priority in many of their practices. There is a crisis in primary care across the province, across the country, and abortion continues to be seen as a bit special and not something that really needs to be adopted across primary care. The other thing that they would encounter was a lack of support from either colleagues or their employers, and then infrastructural barriers. For instance, ultrasound, which, although it's not required by Health Canada anymore for prescribing, is of course still recommended when there are indications where you'd like to know the gestational age and the location of the pregnancy, as well as access to emergency services, right? So even though medication abortion, like a spontaneous abortion, has that rare occurrence of miscarriage, when you have brought it on, there is this concern as the nurse practitioner that you are very responsible for seeking that emergent blood transfusion care in response to hemorrhage. Next slide. So despite these barriers, we did see extremely high uptake among nurse practitioners and among family practice, general practitioner physicians as well. And first trimester abortion care started very quickly to be normalized as primary care. It's very similar to contraception. You get the prescription from your primary care provider, you walk over to the pharmacy fills it, and then you go home. And the symbolic and social, political meaning of abortion in this context is really very revolutionary. So that has been such a tremendous gain for us in Canada. Next slide. We also saw the number of abortion care providers increase. So like we knew people would want to take MIFI, we knew that demand for surgical abortion would shift, and we knew people would want to add MIFI to their practice. We just could never have predicted the extreme response. So within 2 years of having mifepristone, we saw a 4-fold increase in the number of abortion providers in this country. That is just bananas. And we actually had been seeing the numbers of providers kind of fall, just a gentle slope, but the number had actually been falling in big picture over time. And it just shot right up. And surprisingly, in addition to medication abortion providers vastly growing, we also saw this significant increase in the number of procedural abortion providers. We don't have an explanation for that. We just have the quantitative data, but we theorize that people who were doing medication abortion, family practitioners who were doing medication abortion, realized that it was quite fulfilling and sought training and added procedural abortion to their practice. We will do further research to figure this out, but it's very, very promising. So most of these new providers are really just doing a couple. Most are doing under 10 medication abortions a year. This is just a small part of their general practice. This is just primary care. Next slide. This caused a really remarkable improvement in access overall in a country where geographic disparities were one of our biggest threats. The urban rate for abortion providers increased 4-fold. So the number of abortion providers per 100,000 population jumped 4-fold. But fascinatingly, the rural rate of providers per population rose 20-fold. So we are seeing that this actually disproportionately benefited rural patients. So promising. We also saw some changes to the way things are organized. So in Nova Scotia, where I practice, there was the introduction of centralized toll-free self-referral to one number, 1-833-352-0719. You call that one number and a registered nurse will do an intake with you, figure out what your preference is. You know, if you're not too far along, do you want to do medication? Do you want to do procedure? There's 3 procedural abortion sites in Nova Scotia. Where do you want to go? What's easiest for you? If you're going to do medication, do you want to go to somebody nearby? Are you going to do a no-touch option? You could talk to anybody in the province really for that. And a nurse works through that with you by phone. And we've seen there's a similar, not quite as complete coverage, but there's a similar initiative in BC. I've been told by Dr. Helen Pymar that there's things in the works in Manitoba to create a similar system. And certainly in New Brunswick, where I now live, we have a proposal in place to introduce a central line. And we also have a one website that we as independent practitioners launched, where you can get all the different information and can see the picture of where access is possible across the province. Next slide. In the abortion world, we've had to recognize that COVID, frankly, wasn't all bad for our patients. We saw several governments affirm very publicly that abortion care is essential, and nothing would slow it down or stop it during other healthcare service shutdowns. This, for us in Nova Scotia, was the first and only time our government has very proudly and publicly announced how to get our care. We also saw the normalization of telemedicine in general, and lots of opportunities for that to shift individual practice. There had to be some negotiations about billing codes, but we saw telemedicine spread in the medication abortion world. And of course, we have these clinical practice guidelines now published by the SOGC. The link is right there for no-touch, low-touch telemedicine abortion. Really, Canada's catching up with the rest of the world in terms of a home-based, self-managed approach to abortion care. So with all that good news, I'd like to talk about some of the work that I've been doing that's focused on abortion access for some of our most marginalized people in this country, and those are people in prisons. So the next slide, please. We've been working on a multi-part project in collaboration with Wellness Within, as I explained, that has several different pieces. Next slide. So I'll just begin by really emphasizing that the abolition of police and prison forces is a principle of reproductive justice. Incarcerated people experience extraordinary rates of childhood exposure to sexual violence. They also experience sexual violence in prison. They face extreme restrictions to access to services, in particular reproductive health services, because the prison apparatus is designed for men, and yet the fastest growing population in prisons are women, trans and non-binary people. There is a particular and profoundly unethical lack of access to reproductive and gender-based services. Prison causes delays and interruptions in fertility, some of which can never be recovered, and it also causes separation from babies and families. It is profoundly unjust. And every aspect of the prison apparatus in Canada must be acknowledged and analyzed through that lens of colonialism and racism that sees this system as emerging from our very earliest practices of anti-Indigenous racism and violence. And whenever we invest in prison systems, that public funding, because it's a public system staffed by public servants, is always a redirection of care that could be invested in our communities and in our health systems. So recognizing abolition as a reproductive justice project, I've worked for many years to try to convince us as abortion care providers of our obligations to join the movement for abolition and to interrogate our own practices and our own participation in carceral contexts. Next slide. For a person who gets pregnant and in prison or is then imprisoned, it is an extremely stressful and harmful experience. The environment is very gross, very physically gross. It's unhygienic. Your movements are under surveillance and under restriction. You do not have access to food or very basic over-the-counter meds when you need them. You do not have access when you need it to primary care. You are beholden to someone else agreeing that you need and sourcing that care for you. You are not in control. For a pregnant person, this is incredibly alienating and terrifying. And of course, it's very harmful for a pregnancy. People who are in prison are not allowed to know when they will receive care for security reasons. As if you're somehow going to bust out of jail while you're getting a sonogram. And because of that, you don't know what you don't know. So, and I don't know if anybody has ever experienced this, but as a prisoner, because you don't know that you have an appointment, when that appointment is canceled, because, for instance, there's a lockdown in the prison and you're not allowed to leave, you don't know you had the appointment in the first place. So you don't know that you missed it. And you don't know that you are coming across as someone who is unreliable in their prenatal care seeking or in their healthcare seeking from our side of the shop, right? As healthcare providers, we see somebody who routinely cancels, and we see that as unreliable. And really, that person on the other side has no idea that they were even coming for care. We do have we have limited data in Canada, but we have enough to know that there is an association between incarceration and inadequate access to prenatal care, to lack of access to specialized obstetrical care. There's an increased risk of preterm delivery, which of course is the #1 reason for infant mortality, and of small for gestational age and low birth weight babies. So we know that prison right now, this is recent 2020, 2023 analysis, right now prison is bad if you are pregnant. So one of the things we wanted to do, we've done a lot of work over the years looking at different maternal health indicators, was really hone in on this question about abortion. We conducted an international scoping review. So that's where you bring all together all of the existing research about a topic and try to figure out what's been examined so far and what hasn't. And what we found, 20 years worth of studies, 43 studies, 2 of which were based in Canada. And they were across 6 countries overall. So what we saw people looking at was contraceptive use, rates of, types of, abortion rates in your lifetime, usually, distance to abortion care, attitudes, knowledge about reproductive health among incarcerated people, and prison policies in particular regarding who pays for abortion and contraception care. What we saw as barriers to abortion and contraception in this scoping review were lack of on-site access. So things like, well, you can't get an IUD inserted here. No one is competent to do that. So you don't have that option. Contraceptive coercion. Financial costs, this was American where that was coming from, but direct financial costs for patients who are in prison. And disruptions. So when you're in prison, you're covered by this, but then when you're out, you're not. So you can lose your coverage for your continuous contraceptive script because of these incoherences between the institution and wherever you were discharged to, very often to homelessness. So this scoping review has been published open access. The link is right there, and please read it, share it, use it. And so that was kind of the basis for the rest of our work on this topic. I'll just share this this quote from, so the next slide, please, from the scoping review from one of the studies that's included, a qualitative study. It made it seem like they really wanted to put me on birth control here. They asked me a bunch of questions and I answered about sex and stuff like that. Afterwards, they're like trying to get me to start on birth control. And I obviously said no, because I would rather do that not here, because I'm in here. I kind of just don't want more things that I feel I have no control over. That really captures the context that people are living. And we really, as healthcare providers, need to be aware that that is what this feels like. When you're pushing something on someone, even something as freeing as contraception, that will feel really violent in a context of violent coercion. Next slide, please. So our next piece was to replicate what some of the studies had done elsewhere, and in Canada, measure the distance between the prisons that are designated for women and girls. And that's the language that we use, this designated for women and girls, knowing full well that trans and non-binary people are hyper incarcerated and may be incarcerated in prisons designated for girls and women, or not. They may be imprisoned in prisons designated for men and boys. Prison is a gender dichotomous and gender enforcing system. So a while ago, we had built this inventory of these institutions. We measured the distance to maternity care services. So we reused that inventory and we compared that with the 92 procedural abortion facilities that we were able to identify using publicly available directories and in consultation with Action Canada and NAF and ARC. So what we found is that about a third of the prisons were, 0 to 10 kilometers away from procedural abortion, but some were over 300. And one was 738 kilometers from the nearest abortion facility, procedural abortion facility. And you have to imagine that for any patient, when you're leaving the prison to seek external care, you're strip searched before you leave. You have to travel cuffed in the companionship of multiple guards or sheriffs. So if you need to do this for 738 kilometers each direction, I mean, that's horrible for anybody, but cuffed and in the incredible confidentiality violating context of having multiple, likely men in uniform accompany you, really, really hard to picture this. In our analysis, we did say things like, well, this clinic is closest, but it has a GA cap of 14 weeks versus this clinic is another, 5 kilometers, and that gestational age cap is 20. So this is, one measure. Distance is only one measure of your access, but it's an important one to acknowledge. And so next slide. We worked with a geospatial specialist to be able to show what this looks like. And you'll see the little red H's. Those are our procedural abortion facilities. You're on there, of course. And you're one of the ones that's quite close to several facilities. But then you can see there are some that are very, very far. So next slide. One of the things we might conclude as a result of this analysis is like, oh, well, we need to do better with mifepristone in prisons, obviously. And no. As we were talking about earlier, prisons are really unhygienic. And you don't have access to a shower. You don't have access to menstrual products or Advil or a hot water bottle. You are constantly under surveillance. You are never, ever, ever alone, or ever not under the watchful eye. You are literally miscarrying in front of someone all the time, and that someone is not a caring someone. You don't have access to peer support. most disturbingly, you do not have access to emergency services. So if you bleed out, you are not guaranteed to get care. There is not nursing 24/7 in prisons in Canada. So we cannot, in good conscience, recommend that people be using medication abortion in these settings. It is simply not safe or dignified or ethical. Next slide. We also conducted a policy review. So we wanted to know, what are you allowed to do in these contexts, right? What are the prisons saying about abortion and contraception? And we worked with that research assistant, Susanna Mackenzie-Freeman, who conducted freedom of information requests for every province, every territory, the feds, asking for any and all info about correctional policies governing pregnancy, pregnancy prevention, and pregnancy termination. All right, next slide. This is what we got. So only 7 places wrote back to us that they had something. Several places had nothing. So 5 jurisdictions had nothing. And Quebec hasn't gotten back to us yet. We're working on that now. We're doing what we call data extraction and putting together the themes among what they said. And I don't have time, but I would love to tell you the absolutely ridiculous things we found in some of these policies. But just to give you kind of the Coles notes, next slide. Most of the policies are from the justice side. So even though health is usually delivered by the Department of Health in Canadian correctional facilities, or like the health authority, the policies about this are coming from the justice side of the house. So the correction side, the guard side, the programming side. There's generally a presumptive exclusion of any language about abortion or miscarriage. So when it talks about pregnancy, it talks about the mom and baby and their bond and how the bond will be supported. Very inconsistent availability of any statistics about contraceptive prescriptions or pregnancy outcomes. So very randomly and possibly inappropriately, we were given the year and type of pregnancy for one territory. This happened with this pregnancy. This happened with this happened with that. Another province sent us, like in 2015, we had 7 prescriptions for birth control pill type X, but just random, right? It's not consistently collected so that we can see what's happening or how things differ between jurisdictions. In terms of safer sex, just a very strong focus on condoms and STI prevention, not on prevention of unintended pregnancy. And so there you see this like real dominant prisons for men are dominating policy creation. It's just like not even a thought that you would want to prevent pregnancy. Irregular requirements. Some places you are required to have a pregnancy test when you are admitted to custody. Some places you aren't. Some places you're required to do a drug screen if you are pregnant. Some places they don't talk about it. Rarely, there would be specifications about how to handle different aspects of prenatal care, labor, delivery. Several had policies like, if you are in labor, you will be sent to hospital. That's it. That's all we're going to say. And definitely a lack of proactive policy creation. So when you send out a freedom of information request, you'll get a letter back. And in one case, the letter said, this has never happened, so we don't have a policy about it. As if it will never happen that a person will get pregnant or be pregnant in custody in your entire province or territory. So we're working on writing that up. We will publish that. Now, I just want to speak briefly about what the urgent priorities are for our work generally, right? So our team and our bigger community. And the first one is to improve availability of abortion content in our healthcare provider programs, to work on resisting the pervasive crisis pregnancy center misinformation. This is a very important part of access, correct info for the public that we don't care enough about in this country. And it's really deeply deceptive, and especially with social media, there's so much garbage to weed through. So that should be a government priority, to publish correct info. We need funding for people who are migrants, who do not have papers. There needs to be a recognition of this intersection between human trafficking, people without papers, and sexual assault. And the particular, obviously, people who do not have papers deserve all types of healthcare, but there is a particular obligation from the state given this coercive and gendered context. We need to sort out our problems with interprovincial coverage for MIFI. Like, if you're an Ontario student and you're going to Dalhousie University in Halifax, Ontario won't pay for your MIFI upfront. So that's a problem, because those students don't have $400 in their pocket. We need to deal with our later gestational age capacity problems. For instance, I recently dealt with a very infuriating denial of coverage for a young patient who needed to go out of country. And there's this problem. This is an interesting thing. So now, we know we've expanded gestational age capacity during COVID. We know that Mount Sinai has this program, that in Toronto, Women's College has expanded their offerings, and the care program in Vancouver pushing the gestational age. And that's wonderful and so good for our patients. But as a result, we have things like governments coming back and saying, well, this care is available in Canada, so you can't go to Colorado for it. Even though our local programs, which are not very local, you have to go like 3 provinces over, are full, right? Like, so just we've kind of put ourselves in this rock and a hard place by creating capacity. And we need to make sure that governments understand, no, that's not quite how this works. And you do need to fund this, and they do need to go to Colorado tomorrow. And then, of course, following in BC's leadership to advance universal coverage for contraception, that is such a priority all across this country. And I'm very, very hopeful that we will make more and more progress. BC's lead is so inspirational. There was a time when New Brunswick was the first and only province to publicly fund mifepristone, and everything changed. So I'm very optimistic that we can make everything change for contraception too. Maybe my idealism is a little silly, but I'm going to have it nonetheless. So next slide, the things that our team are working on right now. We're working with the Canadian Association of Schools of Nursing to develop guidelines for nursing education and abortion, and also to find out exactly what's happening right now in terms of abortion curricula. The CART Access Project. So we have a very large Health Canada funding project to develop open access resources for people to bring abortion into their practice, whatever their practice might be, from doulas to social workers to pharmacists to obstetricians. My team locally in New Brunswick are working on the first survey of its type to collect reproductive outcome data among people experiencing incarceration in the provincial system in New Brunswick and Nova Scotia. And we're hoping to extend the work that we've been doing about prisons and abortion to include interviews with people in the system, both as patients, providers, and as people who work with the prisons, to find out what is the actual path, what are people experiencing. And finally, always advancing public understanding of abortion and how to get one. I've included some resources. That's the next slide. And the next slide is just how to reach me. Can always email me, my website, and a lot of the resources should be on the website, and how to get the book. So this book is looking at that pathway, taking our lens towards reproductive freedom that we hold so close to our hearts as abortion care providers and advocates and activists, and pushing to extend that compassion and that philosophical foundation to the abolition of policing in prisons.